Now, another important issue to think about is anticoagulation. I mentioned that there is a risk of stroke from doing the procedure, but there's also a risk of stroke from atrial fibrillation itself. Not everybody has the same risk of stroke, but if we're doing an atrial fibrillation ablation, no matter what your long-term risk of stroke is, folks are going to be on a blood thinner for at least a month before and at least 3 months following an A-Fib ablation of whichever type we do. Otherwise, then we look at folks in terms of what's your long-term risk of stroke. And there are a variety of risk factors we look for. There's major and minor risk factors, and these things are taken into account to decide how aggressive we should be at trying to lower your long-term risk of stroke. So, for example, the two major risk factors are if your age is over 75 or if you've had a prior stroke or mini stroke, a TIA before. Each of those would put you into the higher risk group by themselves immediately. They're 2 pointers on the scale. The other ones are minor risk factors, and they're 1 point each. That's if your age is over 65, if you're female, have a history of high blood pressure, diabetes, heart failure, or vascular disease. And that includes coronary artery disease, cerebrovascular disease, or peripheral vascular disease. We total up the points. The more points you have, the higher your risk. If you have 0 risk factors, your risk is truly very low, and nothing may need to be done to try to prevent strokes as a complication of A-Fib. If you have 1 risk factor, your risk is less than 1%, probably about 0.7 based on the studies, 0.7% a year of a stroke on no therapy. For those folks, usually it's either aspirin to reduce your risk of stroke or a blood thinner, an anticoagulant, of which we have now 3 different varieties. There's the tried and true old-fashioned warfarin, which has the advantage of being dirt cheap, but requires monitoring in terms of getting your blood drawn to check to see how thin your blood is so we can give you feedback on how much warfarin to take. There's a therapeutic window that we need to keep you in. We want your blood thin enough to get the benefits of preventing stroke, but not too thin that there's no additional risk lowering for stroke, but your risk of bleeding starts to go up. So the only way to check where you are on that is to sample a blood test. That can either be by a tube of blood in the lab, or sometimes we can poke your finger and get a drop of blood and assay it that way. But then we tell you how much Coumadin to take and when to get it rechecked again. The other 2 agents are newer. They're easier from a patient perspective, but they're more expensive. One is called Pradaxa and the other is Xarelto. Pradaxa is twice a day, Xarelto is once a day. These agents work through a different mechanism than warfarin, but they're equally effective. And the benefits are that we don't have to monitor your blood. It's 1 dose based on your kidney function, and that's it. There's no interactions with foods. So whereas with warfarin, foods that have a lot of vitamin K dependent things, which is a talk of itself, but they can interact with your Coumadin. There are several drugs that can interact with your Coumadin, amiodarone, one of those antiarrhythmics, being one of the big ones. So we have to take those things into account when we're putting people on warfarin. The newer agents don't have any of these dietary interactions or, to any significant degree, any other drug interactions, so they're much simpler. However, they're typically much more expensive. Different insurance companies may or may not cover these agents. So long-term management of stroke risk in atrial fibrillation is something that we individualize depending on a large number of different things. But those are the available options. Aspirin, nothing, aspirin alone, or one of these anticoagulants. Now, let's see. One very important idea to keep in mind in terms of managing A-Fib is that the management strategies are all directed at symptom control. So we're trying to improve your symptoms. There is no data to date that shows that getting you back in normal rhythm or trying to keep you in normal rhythm, either with drugs or with one of these ablation procedures, lowers your long-term risk of stroke. Nor is there any data that shows that doing this makes you live longer. What we do have good data about is that if you have symptoms from A-Fib to begin with, one of these approaches may work well and reduce your burden of symptoms. So symptom management is the primary reason to do this. And we have done, the royal we meaning the medical community at large, has done studies looking at the efficacy of antiarrhythmic drugs in terms of mortality and stroke risk. And the surprising finding was that even when we think we're doing a good job with these medicines and people have no symptoms, their stroke rate doesn't go down. They don't live any longer either. And there's some retrospective data looking at this that suggests maybe maintaining normal rhythm does make you live longer, but being on antiarrhythmic drugs is dangerous, and the two are equally offsetting. So the mortality is equivalent to a rate control strategy. That retrospective look at these trials with the hint, at least, this isn't good science to do it this way, but at least the hint that maintaining normal rhythm may convey a mortality benefit was one of the big drivers that led to the development of the A-Fib ablation. Since if we could do a successful A-Fib ablation and keep people in normal rhythm without antiarrhythmic drugs, they may actually live longer. The study that's looking at whether that really pans out is ongoing, and the data won't be available, and we won't have our answer for another several years. It'll be big news when that trial finishes. It's called the Cabana trial, if you want to look it up, C-A-B-A-N-A. But for right now, in present day, doing an A-Fib ablation or putting you on drugs to maintain normal rhythm are entirely directed at managing symptoms related to A-Fib. And it will not change your long-term indications to be on blood thinners or not. That's an important idea that oftentimes people come in saying, I want an A-Fib ablation so I can get off warfarin. And that's not really going to work.